Okay, y'all don't know this, but this is take two. Personality disorders is what we're going to talk about next. Personality disorders, I think, are one of the most interesting types of psych disorders, just because it's something we can pick out in ourselves and other people. That's why I made your discussion board. I thought was a fun assignment to look around you and pick out different personality disorders, or look at a TV show that we're all familiar with and designate whose personality fits which criteria of which disorder. I just thought it would be fun, and it also will help you learn the characteristics of the different types of personality disorders. So, away we go. Are you prepared? When confronted, a client diagnosed with narcissistic personality disorder states, contrary to what everyone believes, I do not think that the whole world owes me a living. Which defense mechanism is this client using? The correct answer is denial. Denial is being used to avoid facing others' perception. A patient diagnosed with borderline personality disorder coyly requests diazepam. When the physician refuses, the patient becomes angry and demands to see another physician. Which defense mechanism is this patient using? Borderline personalities are really good at using the defense mechanism of splitting. Means they can't feel two ways about one person. So if they get mad at one person, they absolutely hate them. Even if they loved them this morning, if whoever the person is that they love this morning doesn't do what they want them to do this afternoon, they hate them. So that's splitting. A patient diagnosed to the medical floor for diabetic stabilization has a history of antisocial personality disorder. What behaviors would support this? Antisocial personality disorders, you got to remember, these are not people that just want to be by themselves. I mean, we like to say antisocial for people that don't like to be around other people, but the real antisocial personality disorder are the people that are against society. They are like sociopaths. They do what they want when they want without any regard for any consequences. So, cursing when confronted with drug-seeking behaviors is the correct answer. C. A patient tells the nurse, when I was a waiter, I used to spit in the dinners of annoying customers. This statement would be associated with which personality disorder? Or trait, rather. And I think you probably all know this is passive-aggressive. You've heard of people being passive-aggressive before. When they act really nice to your face and then they go behind your back and do something else. So the waiter's being really nice to the patron's face at their table, but when they're not looking, they're spitting in their food because they're mad at them. So your personality is basically how others perceive you, how you act in public, or how you feel in general. Like maybe you like people, you hate people. You know, we all have different personalities. There's different personality types. There's some opposites here. Somebody might be friendly, or they might be angry all the time. They might be grateful. They might be demanding all the time. There's lots of different personality types out there, and I'm sure you've encountered a number of them yourself. We all have different personalities, but we all manage to function. That's the difference in personality types and personality disorders. Personality types, we all have our different personalities. However, we still function. We're still able to get along. We're still able to be nice. We're still able to hold a job, and things like that, function in society. Whereas if it's a personality disorder, you may have some issues with actual functioning and taking care of yourself. So personality disorders affect your ability to interact with society, maintain interpersonal relationships, function in the environment, and maintain a career or occupation. Personality disorders will disrupt your life and maybe other people's lives as well. And even though you may want a very strong interpersonal relationship, your personality disorders keeps you from having one. They can be very difficult to deal with. They're not going to think the problem is with them because this is just them. This is how they've always been. This is their personality. Some personality types can be very manipulative, clingy, or maybe they don't want to be around anybody. Some personality types disorders, can be very suspicious or just odd. And some you just want to strangle just because they're just that aggravating. They're going to think like something's wrong with everybody else. There's nothing wrong with them. Some people you're not going to know how to approach. And back to the diathesis stress model that we talked about a while back. Is there something biologically that is making them have this disorder, that maybe their environment kept it from happening, or they maybe had a little bit of tendency biologically to have a personality disorder and the environment they were raised in kind of made it more pervasive. So, diathesis stress. Okay, let's talk about some of the different types of personality disorders. Paranoid. You've heard those saying, just because you're paranoid doesn't mean everybody's not out to get you. Well, that's what paranoid is. You think everybody's out to get you. Makes you very distrustful, suspicious, unwilling to forgive, reluctant to give up information. Feels like even innocent comments have underlying meanings. Bears grudges. Can be hypervigilant. In other words, they may attack instead of being attacked because they think somebody's after them, out to get them. Projection. They project their shortcomings to others. Usually begins in early adulthood. They're going to be tense and irritable. They're going to be watching. They're always going to be watching. They're always going to think somebody's out to get them. They're going to think the worst. They're going to think everybody's talking about them. They're going to think there's a plot. They're not going to want to cooperate with treatment because they're going to think you're trying to do something to them, brainwash or whatever. Possibly during their childhood, they were the objects of rage or humiliation. And they use, like I said, the projection as their defense mechanism. They project their insecurities onto other people. Specific interventions to be done for paranoid personality disorders. You want to make sure you explain everything to them because they're going to, like I said, think everything that you do or say is going to be trying to trick them or something against them or make them do something they don't want to or cause them some sort of pain. You want to make sure when you're talking to them, you're using language they can understand because they're going to think you're plotting against them again. Let's see what else do I have on here. Possibly let them open their own medications. Let them get food out of the packages instead of bringing them food on a tray. Don't whisper behind their backs. That's why one big reason when you do your IPPRs, you're not allowed to take your paper and pencil into the common room when you're doing your conversation because they're going to think you're taking notes, writing stuff down, plotting against them behind their back. You may have to set limits for people with paranoid personality disorder because, like I said, they can be hypervigilant, and attack before being attacked. They may do okay in group therapy if they can see other people role-playing, getting along. Some medications may be helpful. but there is really no specific medication to treat all personality disorders. Schizoid personality disorders may be the beginning of schizophrenia. They don't want close relationships. They don't want to be around people. They don't care about praise or criticism. They don't care. They're schizoid. They don't want relationships at all of any type. They're totally detached emotionally. They don't take pleasure in activities or any kind of relationships. They're not going to have any friends. They're not going to have any spontaneity. They're going to be cold, aloof, and they take everything very seriously. But they can still function in solitary occupations, perhaps, like air traffic controller was just them and the machine. They're very good at focused, not something that they have to interact with other people. Their childhood possibly could have been cold and neglectful, where they didn't have any close relationships, and they learned early as a child that close personal relationships were not that important. They weren't necessary, they weren't satisfying, so they didn't need them. Depersonalization is what defense mechanism they use, which is where you feel like you are no longer a part of the environment. Specific interventions for schizoid personality disorder is you're not going to cure them. With any of these mentally ill patients, you're not going to cure them. But you do not want to try to throw them immediately into social interactions because you're going to cause a whole lot more anxiety from them. You want to make sure they get regular physical examinations because they're not going to seek out to have a conversation with a nurse or a physician or a therapist. Group therapy might be an opportunity for them to begin some social interactions with other people. Don't allow ridicule from other patients just because they want to be alone. And then there's some medications that may help as well. Schizotypal is almost like schizophrenia, and they have perceptual distortions. They have odd magical thinking. They might be the ones that wear the tinfoil on their head because they think somebody's trying to steal their thoughts. They may dress up like wizards and carry their wand and think they're doing magic or think they're capable of doing magical things. They may think that other people can take the thoughts out of their head, kind of magical thinking. They may have bizarre speech. They're also not going to have a whole lot of social relationships. Ideas of reference means you feel like something else can take the thoughts out of your head, like the radio's playing and you think that it's talking directly to you. That's ideas of reference. They might be rigid and peculiar, superstitious and clairvoyant. Have a bland affect where they don't show hardly any emotions. I think kind of like Sheldon. Do you know who I'm talking about? Sheldon, kind of schizotypal. Was he not kind of odd and eccentric and had believed in magic and believed in well, whatever. I'm thinking that he believed other things had special powers and other things could control him, things like that. That's schizotypal, believes in that, and more than they believe in the person next to him. Could be genetically linked. Derealization and depersonalization are the defense mechanisms of schizotypal. They feel like they are no longer part of the environment, or they feel like the environment is no longer real. In childhood, they may have been shunned or overlooked, which caused them to develop their own magical environment. Specific interventions, you want to respect their need for social isolation. Again, we're not going to try to throw them into social groups. Interventions for suspiciousness, which we already talked about. Frequent diagnostics, because they're not going to seek help either. Group therapy may help them, start to get along with others, but it's going to be long. As for any personality disorders, I don't know if I already said this, you're not going to expect results overnight, no matter what you do with these patients, because this is them. This is who they are. Your personality is who you are. You can't change who you are in just a few sessions. It's going to be long therapies. Schizotypal also are join cults because they're so easily swayed to believe that magical way of thinking. Borderline personality disorder. Now this is, like I said, this is a big one. This is one of those that can make you crazy. Not crazy. Don't mean to say that derogatorily. Anyway, they are unstable. They're constantly in some state of crisis. They have a tendency to idealize others. In other words, you're my best friend. You can do no wrong. Until that person does wrong, and then all of a sudden they hate him. I talked about splitting already. They're impulsive, which means they take risks. They have self-image distortions. They feel a lot of emptiness, so they're really scared about being abandoned. Their moods are unstable. They have separation anxiety, which causes them to be very manipulative to keep you around. They have severe impairments in functioning. They have a high mortality rate. They have a lot of admissions. Borderline means it's a border between neurosis and psychosis. Neurosis being anxiety, extreme anxiety, and psychosis being see things, hear things. They have an inability to be alone. They're always clinging. They may act out if unable to be with the person. And by acting out, meaning self-mutilation. They're cutters a lot of times. Or they may show hostility to others that's not right in their circle. They may also cut because of derealization or depersonalization, because people that cut usually say, even though it's painful, it's better to feel pain than to feel nothing. They have difficult controlling anger. They're emotionally labile. They may have been abandoned in early childhood. They may have an unstable view of their self. There is a biological predisposition, and defense mechanism is splitting, as I already said. We've talked about that a couple times. So when dealing with patients with borderline personality disorder, you want to make sure that you realize that they are going to be manipulating you, and just be prepared for that. Set boundaries, set limits, and make sure everyone sets the same limits, all staff members. Avoid rescuing, because they're manipulative and they can make you feel like they need you, just you, to rescue them. Assess for suicidal or self-mutilating behaviors. Matter-of-fact care for self-inflicted injury, meaning if this is your patient and they cut themselves, you treat the wound, of course, but while treating the wound, you don't focus on the wound. You focus on what's made the patient feel so low that they needed to cut themselves. In other words, you don't go in there and say, oh, this must be really hurt. This must hurt awfully bad. And, how bad you feel for them, because that's going to lead them to want to cut themselves again so that they can get that sympathy from you. That's not what they need from you. And I will probably say this a dozen times. You want to make sure that all the staff are on the same page, the same limits, the same consequences for bending the limits. And because if you have the one person that says, well, just this one time I will look the other way, then that person is going to be manipulated to death, because they're going to just keep going to that person, or telling everybody else, well, this person is the one to go to if you want to do something that the other ones won't let you do. Okay, antisocial personality disorder. We talked about this a little bit already. Psychopaths and sociopaths. They don't care. They do what they want when they want. They don't care. They don't care about the consequences to themselves. They don't care about the consequences to society. They don't care about going to jail. They don't care about being put in timeout. Most of the time, they're going to be court ordered. They're going to be the ones that the police bring in, because they're not going to come seek help themselves. They show no remorse. They lie. They break laws. They're deceitful, impulsive, aggressive. Okay, there are. I know that you probably know people. I'm sure that puts you in the thinking of someone. Maybe not. Underdiagnosed in women, maybe, because you think of psychopaths more as men. But I think there's women out there that feel the same way, that feel like they are above society, or society's rules don't mean anything to them. And they may be overdiagnosed with antisocial personality disorder in lower socioeconomic classes, because those people may be breaking laws just to survive. They may have to go steal just to eat. They may have to fight because that's the kind of neighborhood that they're forced to live in, because that's what they can afford. During childhood, they may have had inconsistent parenting, abuse, neglect. Most likely, if you have antisocial personality disorder, you were probably a bully in school. Could be genetically linked. Maybe lived in poverty, and you learned early that you had to fight to survive. Probably had conduct disorders when you were a child. History of impulse control problems, conduct issues. Defense mechanism is rationalization. It's not my fault, it's their fault. It's their fault that I had to hit them. If they hadn't done that, I wouldn't have hit them to begin with. So, specific interventions, you want to stop them. You got to stop. We talked in the first unit about anger management, basically. Same thing, this is going to be very important in antisocial personality disorder. You want to set limits. Everybody has to set limits. You've got to document signs of aggression. You've got to stop them. You got to stop them before they go off and hurt somebody, including yourself or other patients. It takes being kind of like a warden, even as a nurse, to make sure these patients don't hurt themselves worse. Reassure the patient that staff will intervene if they can't control themselves. All staff have to be on the same page. Milieu therapy may help the patient learn rules, because, in milieu, usually the patients are the ones that make the rules and decide the punishment for breaking the rules. So that's a good situation for them to learn about rules and about following rules. Positive feedback, positive rewards for acceptable behavior. Safety first. Don't sit and argue. None of these patients is ever going to be benefiting from you sitting and argue with them. Be accepting, be honest, keep your promises, decrease stimuli in the environment. Try to help your patient identify what the real source of the anger is. Teach them how to verbalize anger in a non-threatening environment. Remove any dangerous items. Restrain PRN, and you guys are all experts on restraint, so you know all the rules about that. Narcissistic patients narcissistic personality disorder patients are arrogant. They think the world owes them everything. They have a grandiose view of themselves. They think they're very important. They need constant admiration. Usually they're cheerful and carefree until they don't receive the feedback they think they deserve, and that turns immediately into rage. They may seek help for depression because others don't appreciate them enough. Usually underneath, people with paranoid personality disorder feel intense shame and fear of abandonment and afraid of making mistakes. Frequently, they had a cold childhood, kind of neglectful, or their parents are trying to live their life through them and want them to be perfect because parents aren't always perfect. They want them, like for instance, gymnastics. They want them to be the best at gymnastics ever. So they learn early on that second place is not acceptable. Mistakes are not acceptable. They may be overindulged as children, given everything they want, so they feel like the whole world owes them a living. Defense mechanism, again, projection. She should show me more respect. In other words, it's not me, it's them. They're the ones that should be showing me respect. Specific interventions, you want to avoid power struggles. You want to avoid becoming defensive. You want to remain neutral. Convey unassuming self-confidence. Therapy, if you can get the patient to acknowledge there's a problem, psychotherapy may help. Group therapy may help them see that other people are just as worthy as they are. Histrionic personality disorder, these are the ones that want all the attention. They're very impulsive. They can be very melodramatic. They're the ones that will show up to their group meetings in miniskirt and low-cut tops, or guys with skin-tight jeans, or with their shirts open down the front. They may be very provocative. They may be very vulgar. They are going to want the attention however they can get it. They're flighty, meaning they go from one subject to the next. They also demand the best, and they also demand all the attention. They need constant approval, easily influenced by others. And they also may have somatic or psychotic signs and symptoms during stress. They can be smothering, insensitive, and they have no insight into it being any problem of theirs. Yep. During their childhood, they may have had an intense attachment to the opposite sex parent, and fear of retaliation from the same-sex parent. I don't know. I think that's weird. Usually starts at 3 to 5 years old. It may be discovered early that the only way to get attention was to be very flamboyant. Specific interventions: understand seductive behavior is a response to distress. Keep interactions professional. Model appropriate language and assertiveness. Group therapy, and they may benefit from antidepressants. Interpersonal psychotherapy focuses on unconscious motivation for seeking total satisfaction from others and not able to commit to relationships. Okay, we're about to get there. Avoidant personality disorders, they also stay off to themselves. They're going to, if you try to talk to them, they're not going to look at you. They're very sensitive to rejection. People with avoidant personality, they would love to have a lot of interpersonal relationships, but they don't feel like they are able to do so. So they fear rejection. They would love to have a close relationship. I think I already said that, sorry. But they avoid it. Avoidant personality disorder, because they were afraid that they will do something to drive the other person away. Very awkward, very timid, fear of rejection. They may have been rejected as children. Shy as kids, never really got over it. And it can lead to social anxiety disorder as well. Specific interventions for avoidant personality disorder: be friendly, accepting, reassuring. Don't try to push them into social situations, but by all means include them in group therapy if they agree to it. But don't try to force them to talk and interact with others. Teach about assertiveness. Teach assertiveness training. Dependent personality disorders next. Dependent personality disorders have to have somebody to take care of them. Whether it be their mother, their husband, their sister, their mom, they got to have somebody to take care of them. They don't think they can take care of themselves. They like a relationship where they can be taken care of. They don't want any responsibility. They're clingy and they're needy. They have no self-confidence. If one relationship ends, they're going to find another one right quick, find somebody else to take care of them. They do anything they can to gain acceptance from other people. They feel helpless when they're alone. In childhood, they may have suffered from a chronic illness of some type. Independent behavior: if they tried to be independent, they may have been punished. Defense mechanism they use is regression. If they are rejected by somebody, they may go back into a younger person, or something that they would have done when they were younger. Oops. Specific interventions: see what kind of stress they're having. Set limits, but don't let them feel punished. Be aware of countertransference, meaning if you look at these people and you just think, oh, I just need to take care of you, that's not what the best interest of the patient is. There may be some drugs that may be effective a little bit. Teach assertiveness, we already talked about. Don't let them make you their object to depend on, because that's really easy for them to do. Obsessive compulsive personality disorder is a little bit different from obsessive compulsive anxiety disorder, whereas people with obsessive compulsive personality disorder don't have the compulsions. What they do have is a very strict rules. I'm trying to say, sorry. They want to follow rules. They want everything set up in a certain way. They want this to follow this to follow this. And if that doesn't happen, then they causes them bad signs of distress. So they're preoccupied with details in so much that they rarely get anything done. Hoarders. Obsessive compulsive personality disorders are usually hoarders. Not usually hoarders. Hoarders are usually have obsessive compulsive personality disorder, because they can't get rid of anything. They want to keep everything. They're going to be inflexible, rigid, stubborn. But a little bit of obsessive compulsive personality traits are good, having a certain dose of them, because that makes you get to work on time, makes you follow the speed limit, makes you do your homework when you're supposed to, keeps your house orderly. During their childhood, they may have been criticized a lot. They might have been shamed. They might have been told that the rules are the rules for a reason and you've got to follow the rules. And there's lots of defense mechanisms used by people with obsessive compulsive personality disorder. I'm sorry, I feel like I'm missing a slide here. Specific interventions for people with obsessive compulsive personality disorder: guard against power struggles. Try to allow them their own rules, that they will try to make sure that everyone else is following the rules, and it might cause strife between patients. So you got to make sure you're monitoring that. Okay, personality disorders assessment in general. Obviously, you want to know their full medical history. First, before caring for these kind of patients, you want to make sure you assess yourself. Are you able to be manipulated? Are you able to set limits? I mean, these aren't your kids, these are grown adults. Do you feel like you could set limits and stand by the limits without feeling like you are belittling that patient? Of course, you want to assess if anybody's at risk. Some nursing diagnoses related to personality disorders include, but are not limited to, the ones on the slide. And like I said before, you're not going to change these patients overnight. You may never change them, because your personality is kind of who you are, and you really can't change who you are by just sitting in a group therapy session for 1 hour a day. It's going to take a long time to get patients to change. Yeah. So patient needs involvement. You need to get them involved in goal setting. So make clear what the nurse can and can't do. Approach the patients in professional, supportive, and non-judgmental manner. Best nursing approach: clear communication and expectations. Set limits on inappropriate behaviors. Provide structure and support. And direct consistent statements about behavior and consequences. People with personality disorders that self-mutilate, you want to make sure you observe frequently, but do not appear suspicious. Contract with staff. In other words, create a contract. If I feel like hurting myself, I will come and talk to a staff member instead. I will go to the group room instead. I will read a book instead. Remove dangerous objects always. Matter-of-fact care for injuries. I already explained that. Redirect behavior to something constructive, like exercise or crafts. Show of force, PRN. Yes, we will help you get yourself under control. Restrain, PRN. Teach and model appropriate ways to vent anger. Be aware of countertransference. Patients can bring out lots of emotions that the nurse did not know they even had. Positive reinforcement for expressing anger appropriately. Avoid being caught up in manipulative behavior. I'm telling you, these patients will try to manipulate you. If you haven't seen that yet in clinicals, pay attention. Just kind of watch and see if you can't see them being manipulative. Contract, I already talked about. Identify emotions. So try, if possible, not to give them the attention when they're acting out. Give them a little bit more attention when they're remaining calm, doing something productive. Don't allow the patients to pit staff against each other, because that will happen. That's splitting. Well, you're my favorite nurse today. No, you can't have a pain pill. Well, I hate you, and I can't wait till John gets here. Give me that, because he always gives me pain pills because he's the best. Splitting. I love you. I hate you. I love you. I hate you. Oh, I have a video for splitting. I'll just find the videos. I'm going to add you some videos. I thought it was in here. Oh, no, it's in your defense. You'll see it in defense mechanisms. I'm sorry. Going off. Rotate staff so the patient doesn't become dependent on the staff. Focus on feelings. Be available without promoting dependency. Reinforce it is not you, but your behavior that is not acceptable. Staff consistently is very, very important. Milieu management is very important because it gives these patients time to learn acceptable social behavior. And you, as the nurse, should be modeling acceptable behavior. It may take a while to get patients to actually participate in groups, especially the very avoidant ones, the ones that want to avoid other people. Milieu management, the rules are set by patients, punishment set by patients. Other therapies, and I'm going to just let you read this. It's in your slide. Psychotherapy or talk therapy. And dialectical behavioral therapy. That's used a lot for what kind of personality? I can't think of the name of it. Borderline. Sorry, it's right there in front of me. Used a lot for borderline personality disorder. Other types of treatment, group skills training. Team meetings are very important to make sure that everybody is setting the same limits. Group therapy, I've already talked about this, I think. Trying out new social skills in a safe environment. Helps them realize they're not alone in the world. All right. I've got more slides in here that I deleted from yours that has to do with safety. But we've done safety already. So I hope you paid attention to it. All right, let's see. And this one I haven't taught yet. I keep forgetting to remove it, so let's see if you know it. Nail biting, scratching, and hair pulling for extended periods of time in a private setting are symptoms associated with the diagnosis of, and this is an anxiety disorder, and this is talking about biting your own nails, pulling your own hair out. Extreme type is pulling your hair out and eating it, or pulling your hair around here and just chewing on it. And I had a patient once that chewed on her hair so much that she had to have surgery to have the hairball removed from her stomach. And I also have a cousin, it's another form, you pull your eyelashes out. You just pull, she has no eyelashes because she pulls her eyelashes out. I know, that's horrible. The name of that is called trichotillomania. Which student statement indicates that teaching regarding narcissistic personality disorder has occurred? Peculiarities of ideation. Oh, that's a hard word. Constant approval. Impulsive and self-destructive, or express a grandiose sense of self-importance. And we know it's grandiose, right? D. Which intervention would be best to assist a patient with paranoid personality disorder with medication education? This answer is B, provide one-on-one teaching in the patient's room. Because they're paranoid. They're not going to want to let anybody else hear what you're telling them. Patient diagnosed with borderline personality disorder is given a nursing diagnosis of disturbed personal identity related to unmet dependency needs as evidenced by the inability to be alone. Which nursing intervention would be appropriate? Role modeling positive relationships would provide a motivation to initiate interactions with others outside the client's family. This is an appropriate intervention for the nursing diagnosis of social isolation. You always got to remember which answer answers the question. Okay? Inability to be alone. Positive relationships would be the correct answer. There's nothing in this that says anything about suicide. Maintaining a low level of stimuli in the patient's environment, I don't think has anything to do with not being alone, because it sounds like to me it's going to make them more alone. Discuss conflicts evident within the family system. I still don't think that has anything to do with socialization, so that's why C is correct. A nursing instructor is teaching about personality disorder characteristics. Which student's statement indicates understanding? The correct answer is C. Personality disorders cannot be cured or controlled successfully with medication. There are some medications that are used to help patients with personality disorders, but there is no cure. And a patient diagnosed with antisocial personality disorder states, my kids are so busy at home and school they don't miss me or even know I'm gone. Which nursing diagnosis applies to this patient? Ineffective denial. He's denying his child's needs for parental support by turning the situation around and making himself sound like the victim. Okay, I'm going to try to load this on and hopefully it'll work and you can follow along with your PowerPoint. I've had some PowerPoint issues with getting the narrative on there. And it's a work in progress. So you all can let me know if this is terrible or if this is better, this is worse. And I'm going to keep plugging along. Thanks.